Okay. Good morning, everyone, and thank you for joining us for our final day of the 2022 North Country Leadership Summit. My name is Nancy Del Mastro from AHI. We would like to first thank all of the sponsors for this year's event. Without their support, we would not be able to host such a great event, so we are very thankful for the continued support over the years. Before turning it over to Christian, we have a couple of housekeeping items to remind you all of. Please place all questions and comments into the chat box, and during the Q&A portion of the session, we'll be sure to address those with our presenter. Please remain muted during the presentation, but you are encouraged to actually put your video on for this session. So feel free to pop on video. This will be a bit more interactive than some of the other sessions. And as a reminder, all presentations are being recorded and those will be available in a couple of weeks, and we'll send out a notice when those are available for review. And with that, I'd like to turn it over to our presenter, Christian Milaster of Ingenium Health Advisors, to talk about 7 sustainability strategies for telehealth success in population health.
Great, thank you so much. As we're switching gears here, I think I can just seamlessly we'll stop sharing. There we go. That works. Great. Wonderful. Great. Well, so as Nancy mentioned, I welcome you to be off mute, right? So I rarely go and give a presentation or a talk in an in-person meeting and everybody is hiding behind a dark cloak. So always felt disconnected to me. So thank you for the brave soul of Finn here for unmuting. I'll be giving the presentation just to you then today. So I really appreciate it. Excellent. Feel free to post some questions in the chat. We'll have a Q&A session as well. But if I see a question coming up and I just need to see if I can see that window here, probably I can't see it as the presenter, but that's okay. We'll visit that later. But very excited to be back here. Presented a couple of years ago. Also did a session here in the spring. I got a little introduction also about myself here in a minute, but really it's about 7 strategies to make telehealth sustainable, especially for the purpose of population health. And so that's our topic here for today. So with that, the topics that we're talking about, starting off as I always do with a definition of what is telehealth, what does all telehealth all encompass. And then what does sustainability in telehealth really mean? We'll take a look at that and then dive into those 7 sustainability strategies. And under each, there's going to be 3 to 5 tactics. So bringing a lot of material and a lot of input and information to you. Also want to talk about how to launch a new telehealth service, because that's where you actually set the stage for making sure that your telehealth service is sustainable. Then we'll have a Q&A, and afterwards we'll wrap it up with just tying it all together for how to leverage telehealth and telemedicine to advance your population health goals. So that's the topic here for this morning. I hope you had a good conference so far this week. There were some really interesting sessions earlier that I really would have liked to have attended. So I'm grateful for the recordings that will be available. So again, thanks for the AHI team to put this together. So a little bit about myself, born, raised, and educated in Germany, if you already picked up on an accent, and it's not Minnesotan because I did live 15 years in Minnesota, picked up a little bit, but it was too cold, and now I reside, depending on where you are in the state of New York, between 3 and 6 hours south of you, just outside of Annapolis, Maryland. Born, raised, and educated in Germany, as I said, trained as an engineer, worked for IBM, and then came over, worked 12 years at the Mayo Clinic, and then launched my own consulting firm here a little over 10 years ago, really helping healthcare organizations to get the most value out of telehealth, telemedicine, digital health, or ultimately it's about really enabling the delivery of extraordinary care. I'm very passionate about what I do. Love working with the clinicians and empowering them to really do their job really well. So let's start with the definition. And I mentioned I've spent some time at the Mayo Clinic, way too many committee meetings. That was one of the reasons I left. But everybody agreed until somebody defined it. So many times we rehashed the same topics. So I always like to start up with some definitions. for me, telehealth is and has always been just delivering care at a distance. It's really the entirety of all interactions that patients have with a healthcare delivery, with a clinic, with a hospital, and it's all the services, right? Whether it's some education or scheduling an appointment or getting the physician notes or doing a refill, any interactions that we do at a distance are part of telehealth. And then a subset of that, which is mostly what we are concerned about when we think about telehealth, is what I call telemedicine, which is practicing medicine at a distance. So if you put this visually as a taxonomy, you get the overarching umbrella term of telehealth with teleeducation and patient portal, and then telemedicine as a big subset. And that breaks down furthermore into what I call interactive patient care. So that's the telephonic and audio video visits, but also secure messaging. Then we've got remote physiological monitoring, very much of interest in population health with regards to physiological monitoring of blood pressure or weight for chronic care management, and then store and forward as well. So that just to take a look at this in a little bit different way and a similar way, kind of built this matrix here of 9 different virtual care modalities, going from left to right, from simple to more complex, from synchronous to asynchronous, and that is basically the repertoire or the ingredients that we have that we can leverage to really do population health better. Starts with a tried and true bread and butter of telemedicine, telehealth, audio, video televisits. During the pandemic, a lot of the clinicians weren't really trained or introduced on how to use the technology, including the patients. And so many of them switched to telephonic care, and it was interesting to see how much we could actually accomplish. But obviously, it's not as good as in-person care and not as good as even video visits. And then the next level up from that is if you throw in some exam components, right? The video otoscope or stethoscope, especially if you're going into schools or you're going nursing homes or in other. If you have a health system with some outlying clinics, you can do clinic-to-clinic visits and still kind of collect these vital signs even live. Then the whole realm of remote physiological monitoring, so blood glucose or blood pressure or weight or temperature or whatever else, or pulse ox during COVID, really important. There's also technologies around continuous RPM. And then the more complex that I kind of put in this lane as well is that patient-generated health data. I think that's going to, over the next years, going to become more and more important, because the more information we can give the clinicians as to like your step count or your activity level or your heart rate, right? Some people have Apple Watches, or they have a Fitbit, or they have a sleep aid, right? But how can we integrate this data into the clinical decision-making process? So that's going to be also coming forward here, and it kind of is related a little bit to RPM. On the asynchronous simple side, secure messaging, right? It's been proven quite a bit in the behavioral health space. Think BetterHelp and all the other kind of direct-to-consumer services that exist. And I know that even 4 years ago, CMS was looking already at reimbursement for secure texting, and in a value-based environment, really, when we don't have to think about fee-for-service, it's a great way to stay in touch with patients. And then store and forward technologies, like sending a picture with a derm camera or an otoscope, or even taking a little video. And then the kind of what I call the holy grail of digital therapeutics, kind of everything is kind of pointing into that direction. Prescribe an app for treatment, prescribe an app for post-diagnostic assistance. So all these different aspects. So thank you, Susan, for unmuting your video. I really appreciate always live attendance here in the audience. So if you feel compelled to also unmute your video when you finished your lunch, I really would appreciate it. So I have a little bit of an audience that I can talk to rather than just talking into the blue ring of the camera. I feel like a TV announcer some of these days. Good, thank you so very much. So how do we achieve telehealth sustainability, right? So this is really the whole realm of those are all the different things that we can do with telehealth and telemedicine. But what does it mean to be sustainable? And I look at it kind of through three different lenses. I look at it from a perspective of operational sustainability, which means clinicians and patients use it, right? Clinicians recommend it, patients will be using, they're engaged, and so it's sustainable from that perspective. Then there needs to be financial sustainability, so it generates more value than it costs, to put it flippantly. Yeah, value-based environments are really great because then we don't have to think about the nickel and diming of fee for service and do we get reimbursed, do we get paid. We can just allow physicians and clinicians to do what is right by the patient, which I'll get to a little bit later. And then the third one is clinical sustainability. Ultimately, a tool is only as good as the outcomes that it produces, and it's not just from a financial perspective, but ultimately we need to see positive health outcomes. We need to see improvement in population health, to put it even on a bigger scale here. So that's really, so in order to make telehealth, so any virtual care service sustainable, and I'm using these terms kind of interchangeably, then we need to make sure that we do have clinical sustainability and financial sustainability, and what I call operational sustainability needs to be easy to use and to get started. So then the question begs the question, well, what are some reasons for lack of sustainability? And those of you who've heard me speak before know that I'm very fond of one particular change management methodology, which I'll have here on the next slide, the ADKAR model. And so I'm kind of backing at it into it here from a different way. But well, what are the reasons for lack of sustainability? The first and most important one is lack of accountability, right? Nobody's actually looking at the data, holding people accountable, seeing if the benefits are actually being achieved. Is it being used? What are the barriers, right? Because what do we do as humans? We go the path of least resistance. We'd rather do it the way that we've always done it, because that's where we're comfortable, that's where we're competent and where we're confident. And so if we don't hold people accountable to increase utilization, I was talking to an FQHC yesterday, and they said our staff doesn't even collect email addresses for our patient portal sign up, right? So, I mean, it starts at the very beginning of people not being held accountable for the things that are important to the organization. The second one is that reluctance, right? A lack of knowledge. If you don't really know how to use the technology, you don't want to use it, you want to prescribe it. That's on the patient side, that's on the clinician side, that's on the anybody's side. Like if the sentiment is, I don't know how this works, then the telemedicine service is not sustainable. Lack of skills, right? If you don't know the tips and tricks, if something breaks, how do you reboot it or restart it or do something quick? If it doesn't work, and clinicians don't have the time to learn things. If it doesn't work, then they'd rather not use it, and because they have to focus on so many other things. Then the other one is lack of awareness. It's like, why are we doing this? Is this really important? Does this actually work? And do we have evidence? And do we have trials, peer-reviewed trials that demonstrate that this really works? And then the worst one, that is the hardest one to overcome, is lack of desire. So if somebody is just really not motivated and just says it won't work and gives up, so that's the hardest one to overcome. But even that, with some good of the tactics of the 7 strategies that I share next here, that also can be overcome. But those are the 5 areas. So that's, I mentioned here, the ADKAR model developed by the Prasad Institute. It's about raising awareness, creating desire, providing knowledge, providing the ability, and providing reinforcement. And when you have those 5 ingredients in place, then we get change. What happens if we don't have awareness? Well, if people are not aware, then they're confused. If people don't have the desire, well, then they put up some resistance. If they don't have the knowledge on where to find the information or how to prescribe it or how to put in the right billing code or how to use it, whatever it is, then they're reluctant to use it because people want to be competent and don't feel like an idiot. And then ability is, having that training and just knowing how to use the technology or where to get help, right? So that we don't have that frustration. And then last but not least, the backsliding, the reinforcement, the accountability is what this is, what you also need to have sustainable change. And this is to get going here, right? The first four and the last one is to keep it going on an ongoing basis. Good. So how do we provide accountability? So I think it is through, and I'm going to introduce you a few terms that are then put into the 7 strategies. It's around performance management, right? It's monitoring the performance and managing the performance. It's about having leadership engaged, because accountability needs to come from the executive leadership and from management. And since telehealth is a clinical service, we need to have clinician engagement, right? There needs to be a peer support. There needs to be peer accountability of doing telehealth and telemedicine well. And it needs to be financially viable as well. So that's how we can ensure the accountabilities. We need to make sure that it's financially viable. How do we provide knowledge and skills? Well, through well-defined and processed and published and trained on workflows and policies. We need to have user-friendly, or as I call it later on, usable technology. It doesn't even have to be user-friendly, just make it usable. And some of the technology that's out there with the EHRs on the telemedicine side or the patient portal side, some of are not what I would consider usable. And then it's the education, training, and support, which is a very solid strategy to make sure that we have the knowledge and the skills. And then the last kind of pair here, how do we create awareness and desire? Again, it starts with leadership, it starts with clinician engagement to raise that awareness. All right, so now let's look at those 7 strategies here, and kind of basically you saw them on the previous slide. It starts with leadership engagement. You cannot have successful telehealth services if your CEO is not involved. I was at the Michigan Primary Care Association annual conference in person in Detroit last week, and I talked to a few CEOs and said, oh yeah, we've done telehealth, but it's now down to 10%. Moving on, right? So it's not on their radar screen. It's not something that they feel is something that the organization needs to get better at, because I think they have a very narrow tunnel vision of video visits or telephonic care. That's telehealth, and that was just for COVID. So it's not something I need. Whereas really telemedicine is a great tool to advance your population health goal, to solve health equity problems, overcome barriers to social determinants of health, do your chronic care management on hypertension, diabetes, whatever your clinical problems are that you're solving. Telemedicine is a tool to use, and that's the education we need to provide to the leadership. So leadership engagement is key for sustainability. Otherwise, it'll be a flash in the pan, and it'll, like COVID, go back down. Second, and just as important, is clinician engagement. We really have this to be clinician-led because telehealth is a clinical tool, and I have more details on these later. Needs to be financially viable. Actually, I changed that out and sorry, didn't update that slide. And it needs, in addition to leadership and clinician engagement, we also need to have patient engagement. So I have some tactics on that as well. Financial viability, I put under performance management later on. We need to have defined workflows and policies. We need to have user-friendly or usable technology. We need to provide education about why we're doing telehealth or in what way we're doing it. We need to provide training on how to do it, and then ongoing operational support if there's an issue, and technical support if something breaks or doesn't work. Those are really the kind of different lenses. And then ultimately the performance management, which, as I explained in the previous slide, is really about providing accountability, and that goes back to the leadership engagement. Okay, so let's take a look at these 7 different strategies here and dive deeper, and then talk about specific tactics, because strategy is nice, but tactics is where you can actually make a difference. So telehealth has to have an executive sponsor, somebody on the C-suite, either CEO, the CEO, the COO, or the CNO or the CMO, Chief Medical Officer, should have that really that accountability and that responsibility to make sure that telehealth is being used well in your organization. Because telehealth is new and it requires a change in thinking for the time being, 3 to 5 to 7 years, I suggest that, well, I highly recommend, and we establish it at every client that we work with, has a multidisciplinary steering team. Because everybody needs to be involved, from billing to scheduling to rooming to nursing to marketing to compliance. Everybody needs to be involved. And in order to bring this change about, to establish these additional services in addition to the in-person service that you've done traditionally for decades, that requires change, and it requires coordination under the leadership of the executive sponsor. You need to have a telehealth strategy that explains why are we doing it and how we're doing it and what do we focus on. And maybe the theme is we're just going to focus on using RPM for chronic care management or on hypertension and diabetes. Done, right? But that, to say that out loud and to declare that as a goal, is very important for the organization to avoid that confusion and to ideally create that desire. So on the topic of the steering team here, a couple slides that I wanted to share, and I mentioned that, right? It takes a village to do healthcare, and by the same extension, it takes a village to do telemedicine, right? We need to have the patients engaged, we need to have the clinicians engaged, the nurses, the MAs, the schedulers, the billing people, the compliance people, public relations, or marketing and IT. Right, everybody has a role to play in telehealth and telemedicine, and everybody needs to play their part in order for telemedicine to work. And so, from a leadership perspective, you got to have a steering team that has the typical leadership responsibility, establishing objectives and providing accountability. What are the goals for the next 3 months or for the next year, based on that strategy? And then holding the organization, the clinicians, the clinical services, the support people accountable. And then also, as you're expanding, it's to provide requests and provide resources so that you really then have the ability to talk about it. If you are interested in more information on many of these topics, and I have it at the very end, on my website, I have published over 150 articles, and there's a search box, and so you can search for any of these terms. And typically, I've written an article. This is just a screenshot here of that main image. But if you want to learn anything more about all of these different topics, you can find more information there, or just email me. Happy to share more resources that are already freely available. Few guidance here, structures, a couple slides on telehealth strategy. Again, my goal with this presentation, and you will have access to the slides afterwards as well, and the recording, is that you can take different, because I'm going to be introducing, I think, 16 different tactics here. You can take the one that you want to use, and then you can use this as a starting point, and to share with your leadership team, to share with others in the organization to get started, and then to customize it for your own organization. So why do we use a strategy? And again, it's about change management, raising the awareness and kind of providing the clarity as to why we are using telehealth, or what aspects or what version of telehealth or virtual care we're using, creating that desire, establishing a focus, right? There's so many things we could be working on, and we have limited resources, limited time, limited staff. So really providing that focus, that clarity, and prioritize those projects so that then we can allocate resources, meaning money, time, and staff and skills to that. So that is the rationale for why you would want to spend time on a strategy. And most of our strategies are 2 pages, right? There are vision, some objectives, and a timeline as to what projects to launch over the next 6 to 18 months. So it doesn't have to be really a complicated document. It has kind of these elements that you can use as an initial structure. Obviously needs to have a vision. It needs to have what I call strategic alignment, meaning you need to tie the telehealth strategy back to your overall organizational strategy. Again, I have written multiple articles about strategy development. You need to build the financial case for it. Is it value-based? Is it chronic care management? How are we going to pay for it? Just in general, what are the use cases of the different telemedicine services you're going to launch? The technology strategy, how do we market that and do internal change management? And how do we engage leadership and support? Again, that's that strategy. So that's a sample table of contents or elements that your strategy should address. Good. And I think there was a question coming up, but I guess I'll see it later. Good. Clinician engagement. second topic. So I want to start with saying it, and I've said it multiple times already. Telehealth is a clinical tool. It's not a technology. It's not a process, right? Just like a clinician can decide whether to order a CT scan or an MRI, they can decide that doing RPM for this patient or doing a video visit as a follow-up or sending them some messages. That is ability here to use telehealth well. And so telehealth is a clinical tool, and that's why we need to have clinical leadership and clinical engagement, because telehealth is a care delivery modality and in itself is a clinical service. So a lot of people put it historically under, oh, it's a technology, it's using WebEx or using Zoom or using the telemedicine system, or we go with a vendor to do it. So it's very vendor, very technology centric and driven, but it shouldn't be. It's about the clinical workflows and the clinical decision process that goes into deciding when to leverage and use telehealth. And that really is, for some organizations, a mindset shift that needs to happen in order to make telehealth sustainable. So with that, then, to get clinician engagement, we need to assign a clinical telehealth leader. It could be the chief medical officer if they're excited about telehealth. If they're not excited about telehealth, then find somebody else who is excited about telehealth and use that also as an opportunity for leadership growth and leadership development. You got to design those telehealth workflows to enable each provider to practice on top of their license. And I've borrowed this term, right? This term is typically used for different delineating between what physicians can do and what advanced practice providers can do. But what excites me about this from a systems engineering and efficiency perspective is do only the things that only they can do, right? Let's design the work. So clinicians should never do technical troubleshooting, right? They should not help them to get their microphone unmuted on their Apple phone, right? I mean, that's what they should not be spending their time on this. They should be only doing the things that only they can do. And the same applies for nurses, the same applies for the MAs, the same applies for the schedulers. So everybody should have their understand the role and maximize to do those things that they can do, that they're skilled and can do well. The other part to engage clinicians is you got to select user-friendly technology, which means you got to involve the clinicians in the selection process. It should not be your CIO that decides which telemedicine system is the best. That's like somebody in purchasing telling the surgeon which scalpel to buy because it's cheaper, right? No, the surgeon will tell you what they need, and then they do. Now, our clinicians have not been empowered or experienced or knowledgeable enough to know what they need. And so then they just get, and with the EHR, I understand why, well, I'm still mad about the EHR, but I have been for 20 years, and I'm doing penance for the sins committed by the EHRs. But it's really, clinicians need to be empowered and knowledgeable about influencing the decision as to what telemedicine tool really would work well for their workflow, for their mindset, for their care delivery. And that's, again, another mindset shift that we need. But this is how we make telehealth sustainable, is we get the clinicians engaged into designing the workflow and helping to select the technology. And we revisit that later on. The other thing that's really frustrating, and a lot of physicians experienced it and now have a really negative sense of telehealth, is that we need to offer patients who don't have that, we don't know much about, what I call a telehealth tech check. So we've instituted that we call the patient not the same day off, but a few days before. Now, you can also do a self-telehealth tech check, and there's some good solutions out there that can be done. But yes, call the patients. Here, I'll send you a test link. Okay, everything looks good. Oh, it seems like you're sitting in front of a really bright window. You may want to turn around because right now your face is really, really dark and we can't see you, right? So just a few things. I know that Geisinger, for example, they hired 4 people to do telehealth tech checks because their physicians were just saying, I'm not doing this anymore. So I'm not a technical support person, right? I just want to go into the waiting room, admit the patient in, and they're there. And you take care of everything else. And so they, a large health system, obviously, but they hired 4 people to do those telehealth tech checks. And then we need to provide education, training, and support for the clinicians so that they really can do only the things that only they can do and focus on that exclusively. And that's how you build clinician engagement. And that is really the key linchpin to telehealth sustainability. If clinicians like using telehealth, if they see it as a valuable tool, telehealth will succeed and will go on forever until we have new digital health technology to supersede. But it really all the efforts need to center around the clinician. And with that also then we're facilitating our conversations around what are the clinical guidelines for the appropriate telehealth use, right? So obviously if you have a follow-up visit for going over some lab results, then yeah, that's very appropriate. And there's actually way more things that are appropriate to do telehealth for than people initially think. But that's a dialogue that needs to happen. That's why we need to have a clinical telehealth leader that can facilitate that discussion and said, hey, what are our guidelines that we use to make sure that a video visit is appropriate or a phone is appropriate, or where do we prescribe remote physiological monitoring? Good. So that's the second. The third one is, as I mentioned in the list, patient engagement. So really want to enable clinicians to utilize telehealth confidently and competently, because when you do that, then the patients will be engaged. Right. It all starts with one of the reasons that telehealth or video telemedicine failed during COVID is that clinicians didn't feel confident and competent. They felt like a fish out of water. Nobody taught them that to establish rapport with a patient, you have to kind of stare into the camera. You can't stare at that image. Like right now, I mean, you can looking at Susan and Finn. Now I'm looking back at you, but this is how you feel that I'm talking directly to you. And that's what clinicians need to learn, and nobody taught them. Everybody said, here's a webcam and a Zoom license, go do telehealth. And then the patients didn't know how to use it. And so it starts with confidence and competence in order to have patient engagement. The second one is then, as I mentioned before, enable patients, empower them to use telehealth well by providing a telehealth tech check. And then also let the clinicians select the appropriate telehealth modality to create engagement. Is it texting? Is it phone? Is it that? Again, we're still constrained by fee-for-service thinking and approaches, but if we can apply telemedicine in value-based engagements or around outcomes-based arrangements, then really it's a clinical tool that clinicians can yield. So here's kind of what we suggest you cover in a telehealth tech check. Just multiple items, looks like a lot, but it's not really much. And again, I've got information here about an article that I wrote about this, but confirm which location. Don't be in the car, don't be driving when you're in the car, or if you're in the car, be parked, right? What technology are you using? Are you using a smartphone? Are you using a tablet? How's your connectivity? Can you join? How's your audio video? What's the camera angle? How's your background, your lighting? And make sure that maybe you have headsets or that your conversation cannot be overheard, right? So those are the simple. So we need to educate patients on how to do this. It takes 5 minutes to just walk through this once you've got the patient set up, but it will do wonders for the next telehealth visits that they have. All right, fourth strategy, workflows and policies. Document, so here the key is to first document those workflows for the 7 key telehealth processes, and I'll bring them up on the next slide, and then also create the policies and keep the policies separate from procedures and guidelines, right? So policies is, well, I'll have that on the next slide. So that's the guidance as well. You need to have policies that kind of capture the legal essence of consent and licensing and all these other aspects, and they stay fixed, whereas procedures and guidelines are a little bit more varied, and then provide training and support on those workflows, on those policies as well, for new staff or for staff who are not using that very frequently. So here's, I'll introduce you to a new English term, and as a German, we make up very long words in German, but this is a thought word, but it's a condensed word. The 7th force, which stands for telehealth workflows. So it's just a little bit things. So here are the 7 ones. Obviously, at the core is actually doc, right? Doc, I think, was one of the 7 dwarfs here. And that's the telehealth visits. That's at the core. Then we have telehealth scheduling. We have something that happens right after the visit, like prescriptions and follow-up visits. We have some follow-up maybe in the week after. We have some billing that needs to be done, and probably doc needs to enter the right codes and the right modifiers and everything. We have a rooming process as well. We need to collect vital signs, chief complaint, right, and how we're doing this and recreating this in a video environment. And then the telehealth onboarding is where I put the telehealth tech check. So if the patient is doing it for the first time, let's help them to get a good start, just like we would have them fill out all the forms when they become a new patient. So if they're a new telehealth patient, there's an onboarding process. So here are your 7 forms or your 7 telehealth workflows that you need to define, right? And this is the front office staff or the patient service representatives. And this is a tech check support person, and then this is a nurse or an MA, and then this is the physician, and this is a nurse and an MA again, and then this is maybe a front office staff again, and this is the billing staff and the coding staff, right? And that's why I said it takes a village. You got to define that. We are developing for video telemedicine a parallel healthcare delivery system, parallel to the in-person environment. And so that's the workflows that need to be defined. And then each and every step, you need to look at the different policies, and most of them are around the visit and the billing. Because policy and procedures are like playing Monopoly. Procedures move you forward, and policies keep you out of jail, right? So make sure that you separate your policies and procedures, because policies should stay fixed unless the legislation changes. And that's you focus on, and you separate from the procedures which are fluid and which can move very quickly. Good. 5th strategy. And thank you, Susan, for responding to this joke. So that's why I had you on without video. So good. And if anybody else feels compelled to be off video, I will not pick on you. How about this? I will promise to not call you up by name. So, all right, usable technology. Very important that we select the technology to fit the desired user experience. In healthcare and health IT, it has been done backwards for so many decades that everybody thinks that is the right way to do it. And I tell you, it's not. I've worked in other industries before, and their technology gets selected based on the need that you have, right? And so it should not be based on IT's preference, and clinician participation is critical. And obviously, for usable technology, you need to have ongoing technical support and also some training as well. So what I call this workflow-driven telehealth technology selection. So first, you think about, well, what experience do we want our patients to have? And what experience do we want our clinicians to have? You look at those 7 telehealth workflows there, and you just think it through. Like, how do you do the rooming? How do you do the follow-up visit scheduling, or the prescription, or how does this all work? How should it work in an ideal environment to provide really great customer service, to provide really good patient service? So you got to define the core workflow of what this is, and you got to be cognizant about what happens before and after. Those of you who have done some workflow development will know what I'm talking about. But then then you pick the technology that helps you to select to support this particular core workflow. So that's the first part. And don't put the horse behind the cart. And I know that the English idiom is actually the other way around, but what I mean by that is most organizations first buy the horse, or actually the IT director buys the horse, said, here's our telemedicine system, and then, oh yeah, let's figure out what cart we want to push. And well, while this may work, probably it's not as effective and efficient, and the cart probably will go all over the place, and the horse will not be very motivated to move if it all looking is just at the cart in front of it. So first, design your clinical, operational, and financial workflows so that they can around that they can only do the things that only they can do, and then select the technology that best fits your needs. Now, do you have to do this right now because you already have existing telemedicine systems? No. Most of the technology can be made to work relatively usable with a good workflow, with good training, and with good support. But over time, evaluate whether this particular tool is really serving you well. There are some customized solutions in behavioral health, for example, that allow you to do an in-visit PHQ-9 or do some other interventions. So there's point solutions out there that go beyond just the video capabilities. And as you have become more mature in your organization, you can look at those. Good. So education, training, and support, I think that one is pretty straightforward. So share and promote the telehealth strategy, right? That's the education part, raising the awareness, creating the desire. Then provide workflow training to all users, interactive training. So sit down with them. We're actually launching that at an FQHC in rural Virginia. Next week, we're going to sit down, we're going to walk through with the front office staff. Here's the steps that occur when the patient shows up for a telehealth visit with a provider at another clinic. So we're walking them through the steps, and then we're leaving them with a cheat sheet that they can quickly refer to, because they don't do it every day or every week even sometimes. Provide the technology training to all users, again, interactive training and cheat sheets, and identify and designate operational and technical support. Doesn't have to be full-time, but somebody needs to be, can be reached if there's a problem or a question. And obviously you also need to do ongoing training for new staff as they come on board. And that operational first contact can also then provide technical support. And I think I have so let's bring this all together, what I've talked about in the leadership engagement, clinician engagement, and then in the support, because I've kind of built this hierarchical org chart here for telehealth support. At the helm is the executive sponsor, the executive liaison. Then we have the telehealth steering team with multidisciplinary representation. Then we have the telehealth support team. And then we have the ongoing management and operations. So the scheduling and the conducting, that is managed by the clinical teams, right? If you have multiple clinics, each clinic manages their own kind of telemedicine services. If you behavioral health does their own workflows, and primary care does their own workflows, and dental, if they have teledentistry, does their own workflow. So the day-to-day ongoing operations needs to be owned by each team, because it's just a parallel healthcare delivery stream. If you have remote physiological monitoring, obviously that may be a little bit different, but even there you want to house it in population health or with the case managers that are already doing kind of chronic care management. Telehealth support breaks down into 4 different areas. The 2 of them here I already mentioned before, the operational support and the technical support. And this is all just means that somebody in the IT team is designated as the primary contact for telehealth support and troubleshooting. In operational, there's somebody you can go to if you have a question or need more training or something is not working, just somebody to go to. In addition to that, also, you can think about doing launch support depending on the size of your organization. If you're launching, and you saw the matrix of the 9 different virtual care modalities, if you're launching more and more services in different environments, you need kind of a launch methodology, which I'll have next year if we have time, although we may be a little short. And then also ongoing optimization support, ongoing improvement of the workflows and the technology. Good. Then performance management, last of the 7 strategies, but one that really ties it all together, because that really, so once you've got the flywheel going, to keep it going and to prevent it from stopping, it's really about performance management, and it's about identifying the meaningful metrics, establish some objectives, some goals for those metrics, and then one really powerful tactic is to actually predefine actions, and I'll explain in a minute what I mean by that. And so the metrics that I suggest you look at, especially if you're just starting out or are in general maybe immature as an organization to manage by data, to do fact-based management, is clinician, staff, and patient satisfaction. And you don't have to collect this on an ongoing basis. You can do periodic snapshots. We do quarterly assessments for 5 days, saying, "Hey, tell us," or so we just take the pulse, basically, right? We take a quick snapshot just so we know where we're going. We need to manage the financial performance, obviously, and we need to monitor technical performance and monitor utilization. The reason why I said monitor is really, and maybe it could be managed technical performance, but it's monitoring utilization. The goal is not to reach some artificially set goal of telehealth utilization, right? I don't know if 35% video visits is great, or 65 or 8%. But you got to monitor it so you get a feel for what's going on and what are the trends. And there may be seasonality. We're coming up on winter, on snow, and so and maybe you need to prepare for that. So get familiar. So it's really just about monitoring volumes, modality, video versus telephonic. Especially if telephonic is no longer reimbursed, you want to monitor that. Where's the patient located? Right? Are they at work? Are they at home? Are they in a car? Are they in a different clinic? So just get a feel for how people are actually using telehealth. I've seen most leaders are completely in the dark when it comes to telehealth utilization. And so, so there's kind of 4 elements. You need to define the metric. And again, you have this in your slide to work through. You need to assign some ownership, who owns the metric and who actually operationally collects it. And then you need to set, and that's at the steering team level, what are the goals, what are the target, what level of satisfaction do we want? I'm aiming for 4.5 on a Likert scale, on a 5-point Likert scale for clinician satisfaction, and 4.8 and higher for patient satisfaction. Those are the goals that I'm aiming for. And if we're not there yet, then what interventions can we launch to optimize it? And what you can do, and that's what most organizations don't do, is you can predefine action. Okay, and maybe the predefined action is only to say, okay, do a root cause analysis or figure out what's going on, right? Because we can give these operational data collectors the guidance during the same time that we're establishing the goals, we can think about what actions do we want the organization to take in order to get us to that level. And it's a quick conversation, but it makes the metric collection so much more meaningful. Because data collection is expensive, and so we got to make sure that we have it. And so here are kind of the KPIs. The pulse is, for me, a satisfaction at this point because it's about change management. We got to monitor those and manage the performance of the technology. So how many problems did we have? Look at visit volume and modality, and then the financial performance. So these are the kind of 5 basic metrics, 5 basic key KPIs that you can be measuring, and they're relatively easily to obtain, but that's how you do performance management. So with that, we have those 7 sustainability strategies: leadership engagement, clinician engagement, patient engagement, the defined workflows, usable technology, and education, training, and support, and then putting it all together and keeping the flywheel going around performance management. And I also just provided you this kind of 1 slide of all the different kind of tactics that we've talked about that are all played together in terms to make telehealth more sustainable. We're at 11:48 a.m. here. I did have some slides on launching the telehealth service, which I'll skip. Because I want to make sure that I address some of the questions that people may be having here. And I currently cannot see any chat windows, so
Yep. I could take care of facilitation. Thank you so much so far. It's been awesome. I'll start with a couple of comments. Donna mentioned that Telehealth Tuesdays are the best, which they are, and we encourage everyone to sign up to get those from Christian. Another comment from Peter: another outstanding and comprehensive presentation. So much to digest. Thank you, Christian. Your insights are always enlightening. And for a couple of questions.
Okay.
Noticed some of the insurance plans are framing out the telehealth services. What are your feelings on this idea?
I'm sorry, I didn't catch the keyword. They are what?
Farming out? Or
Oh,
like phasing out? Yeah.
I don't like it. I don't like it. I mean, I grew up at the Mayo Clinic, and what I learned about is continuity of care and care coordination. And what these insurance companies are doing is, I understand. I mean, yes, we can do a lot of things about just from home if we have a little urgent care problem. And so I understand why they're doing it. But the problem is that those outsourced telemedicine service. So they engage Teladoc or MD Live or MWell, right, as a first point of contact. But that interaction, that clinical note does not get sent to the primary care provider. So there's no coordination, and as a primary care provider, you're basically left in the dark as to what's going on with your patient. And so they get fragmented care where there's no coordination, no history, because the patient may forget that they're taking this medication that they've been taking for 8 years, and it has a counter indication. And so there's so many problems with it. And so I I really don't like this use. And that's what I've been telling our clients, is that that's exactly the reason why you need to become better at telehealth and telemedicine, because and so the FQHC we're working with in Virginia, the CEO had some conversations with the insurer, said, hey, can we be your telemedicine company for our patients, right? And so because they're investing now in telehealth optimization in their organization, that is the better solution. So yes, I'm concerned about this. They paved the trail. But what the insurance companies should be doing is they should be forcing for these outsourced telemedicine companies to document it into the primary care physicians' records, and the PCPs should get paid for reviewing that information. So that's what should happen from an outcomes perspective, from a long-term outcomes perspective, not a quarterly performance for the insurance company, but like a 10-year performance of the patient's health and patient's health cost.
Thank you. Next question is, what will telehealth and telemedicine look like post-pandemic when the federal public health emergency ends? I feel like people have been asking this for a couple of years now. Will telephonic still be allowed, and will patients be able to engage from their homes?
Well, I'm not a politician, and even though I'm close to DC, I'm try to stay away from the hallways of the alphabet soups there of HRSA and CMS. Telehealth was already in a great spot before the pandemic. A lot of people forget that. Medicare was trying so hard to allow a reimbursement. Their hands were tied by a statute that was put in place by Congress in 2001 that was at the time ill-advised and still is, but it takes a heavy lifting of bipartisan decision-making to overcome this. But CMS was in full support of paying for telehealth and telemedicine service, but had that limitation of it can't originate from the patient's home. And I think that is definitely going to disappear. I mean, that's gone forever. I mean, we have now, that's going to be gone forever. Most states have by now passed telehealth coverage parity, and many states have now passed telehealth payment parity. Many Medicaid programs that I'm aware of also reimburse for telehealth, reimburse for remote patient monitoring. Here in Maryland, they're paying $120 per month for RPM, which is a fair rate, which covers the cost of a lot of those vendors. And so yes, I think it's all there. The ones that are hurting most and the ones that upset me most, because we have payment parity in a lot of centers. Now, New York was very aggressive, right? And they had coverage parity, and some behavioral health providers, because I worked with an FQHC in Vermont, and they had clients from New York and were taking the health plans as well, right? They were taking 50 cents on the dollar for telebehavioral health services. But I think there was a big uproar, and then I think they've taken it back. That was late 2019 or early 2020 when I heard about it. So those attempts will be made by those by the bad players in the insurance industry, and offense intended for any insurance representatives that are on this call. So let's have a conversation about how to improve healthcare. So I am very bullish. The one thing that I really don't like is the reduced payments for FQHCs and rural health clinics. I don't understand why they only get paid $95, $98 per visit, because compared to an RHC rate or to the all-inclusive rate of FQHCs, that's just ludicrous, because it is excellent care. And so while at least they're allowed, and I think that will stay, it was just extended another 2 years, so we have until end of 2024. But we really need more lobbying efforts to really make clear that there should be payment parity between telemedicine and in-person care, because the FQHC serve the most vulnerable population that oftentimes does not have transportation, is working 2 jobs, doesn't have the time, doesn't have childcare. I mean, all the things. And so why would you not pay at par for a telemedicine visit? So I don't understand, because that's the kind of really the last point, the last domain where there's no payment parity. And so that's, yeah. that's my take on it. So I'm bullish on it, and as politicians do, like don't they have to make a decision this today to keep the lights on? So they kick the can down the road. So I think we'll just see the can kicking down the road. But I really would like to I'm participating in efforts to lobby for parity payment for FQHCs, because a lot of our clients are FQHCs that we're working with. So good. All
Great
right.
points.
Feel free to reach out to me with additional questions. I always love to chat or be invited. So you can ingenium.net, that's cut off here if you look for my email. All right, let me just tie it all together with population health here. And some of you may have seen this because I just borrowed these slides from my presentation in April. There's two goals to population management: chronic disease management and preventive health. And I'm just going to give you some kind of inspiration as to where to leverage the different virtual care modalities for these two domains. So starting again, just as a visual reminder, right? Those are the 9 virtual care modalities that I talked about. And so for chronic care management, obviously remote physiological monitoring, right? Hypertension, heart failure, diabetes, COPD, all the different tools are available to get daily periodic measurements, and then have a monitoring nurse oversee it, and then escalate as needed, do medication adjustments. Follow-up visits to review lab results obviously can be done with televisits. What I mean is televideo visits, could even be telephonic. There was a question about telephonic. Every state is managing it differently, but a lot of states are now paying, state Medicaid programs are paying for telephonic behavioral health. And I think also CMS, I think, is paying for Medicare telephonic behavioral health, but I'm not quite sure about that. So there's some precedent there. On-demand teleeducation about diagnosis, treatment, and self-care, and behavioral health counseling with televisits, right? So those are just some examples. And live tele-exams, again, if you're in chronic care, if you're in assisted living facilities or nursing homes or in schools, right? If you need an exam component, that's where telemedicine can help. And for preventive care, again, it can be the remote physiological monitoring or digital health apps. That's when we get into digital therapeutics. And for tracking and monitoring if they're pre-diabetic or they have risk factors or family history. Again, education obviously is one aspect, having to provide knowledge and also provide education. Again, the visits and digital health apps for meditation, mindfulness guidance. I think that whole realm of helping people with some prevention and case management, social workers, right? Those aspects. Again, over video, you can have a much better connection if the other party is off video as well. So. Thank you. All right, with that, we covered the 7 strategies and a whole slew of different tactics that you can apply in your organizations. Feel free to follow up with me if you want to dive deeper on any of the topics or need some guidance, or need me to come to your executive leadership team and tell them why they should be investing in telehealth. Always happy to do that. And with that, I thank you so very much for the opportunity. Thank you to the great team at AHI to inviting me back here and sharing what we're learning, and we're learning every week. And with that, I thank you very much for your attendance, and have a great, wonderful, brisk weekend, I guess, is ahead of us here.
Thank you so much, Christian.
Thank you, Christian.
Yeah, a lot of great comments. People say we need another hour with him. And we have a couple of questions that we didn't get to. So I'll go ahead and forward those to you with contact information so we can get some answers for our participants. Again, this is being recorded, so you could come back and reference it. I also placed the link to the presentation Christian did for us back in spring, so you could also watch that. And again, thank you so much to Christian and all of our participants for making this such an interactive session.
You're welcome. And thank you to Finn and Susan for being off camera. I really appreciate it. And obviously you guys as well, Sarah and Nancy. So appreciated that.
Of course. Thank you, everyone. We hope to see you at our final session this afternoon at 1 p.m. Thanks, everyone.
Thank you. Bye, everybody.
Bye-bye.